The approach to polytrauma in children, looking at the differences between children and adults, the primary survey and the secondary survey. Child polytrauma differs in the type of injury incurred, usually due to blunt trauma, anatomical features affecting resuscitation technique and equipment, as well as the physiological response. In the primary survey, we assess the A, B, C, Ds of the patient. It is important to stabilize the C-spine until injury has been excluded. If an oral airway is necessary, exclude a gag reflex. Endotracheal tubes are inserted using a straight bed laryngoscope under the age of 1, and a needle cricothyroidotomy can be used in a compromised airway. Breathing is assessed clinically on blood gas and on pulse oximetry. If inadequate ventilation is suspected, check for aspiration, attention pneumo, or incorrect placement of the ET tube. Prophylactic ICDs can be placed for patients requiring ventilation or general anesthesia. When managing the circulation, it is important to stop the bleeding. Tachycardia is usually the earliest sign of circulatory compromise. Other clinical signs of shock include decreased capillary fill time and level of consciousness. In failed resuscitation, consider the conditions on the screen. Closed head injury is common in children. Obtain an early neurological status using the AVPU scale. Also assess the pupils to screen for focal injury. We now move on to the secondary survey. In moving to your secondary survey, your patient should be hemodynamically stable with a secure airway. The primary survey complete and reassessed. Continue to monitor patient vitals and avoid excessive heat loss in children. A detailed history can now be taken from the patient using the AMPLE template. Head and neck evaluation includes a complete neuro exam, GCS grading, routine investigations, and relevant special investigations. Primary injury is usually irreversible, but secondary injury is preventable by adequate resuscitation. Here are some of the common head and neck injuries in children. In the thorax, injuries are commonly minor rib fractures or pulmonary contusions. Pleural collections are usually small and should only be drained if clinically indicated. Watch out for life-threatening injuries such as a ruptured diaphragm or cardiac contusion. Before examining the abdomen, first decompress the stomach with an NGT. Intraperitoneal hemorrhage is usually self-limiting from these organs. Macroscopic hematuria or loin mass or tenderness are indications for IVP or CT. Indications for laparotomy are as on the screen. Children have developing bones and physis fractures are common. In open fractures, early debridement and antibiotics are important to prevent infection. Beware of compartment syndrome, which is the increased pressure on the osteofascial compartment causing ischemia of that. Here are some red flags of non-accidental injury in children. We hope we have given you an approach to the injured child.